Can people just give me a quick chat response, just telling me where you guys are from, what level of education slash training you guys are in? New Jersey. Awesome. Really happy to see a lot of people here. I actually started, well, I didn't start it, but Dr. D'Amico approached me 2 years ago, 2 summers ago, after I finished my first year. And I've been kind of involved in the brain turns process ever since. And really just, it's been an incredible experience connecting with you guys. Wow. I see people from Dubai, Brazil, South Africa, Malaysia. Wow. So good morning, good afternoon, wherever everyone is. I'm gonna get my slideshow started. We have a lot to cover today. Share my screen. I see people are studying for MCAT. Some people are in medical school. Some people are PA students. Awesome. I'm actually studying for my second board exam, my step 2 exam. I'm taking it next week. So wish me good luck. So I'm gonna try to share my screen. Quinn, I don't see a share screen. Oh, here it is.
It should be at, yeah, the bottom.
Yep, got it. Can you see my screen?
Yes, we see it.
Perfect. I'm gonna minimize this. So I do want you guys to be interacting with me. It's too bad we can't have everybody show their faces, but I'll be kind of checking the chat. It's right here. I have 2 screens going on, so I can definitely check this out as I'm going through the lecture. So we're gonna get started. Again, for people joining in right now, my name is Brendan Rue. I'm a 4th-year medical student at the Zucker School of Medicine at Hofstra-Northwell. I've been working with Dr. D'Amico and the neurosurgery team at Lenox Hill, Dr. Bogvar, Dr. Langer, on this brain turns project since 2 years ago when COVID hit. So we did a 8-week, it was 8 weeks back then. And we actually had, I think, 8 medical students, including me and some of my friends, give like an 8-week, we had a medical anatomy course each week covering pretty much every organ system, including the brain and the spine. So shameless plug, I encourage you guys to check that out in the Brain Turns YouTube account. It's going to be a lot meatier. It has a lot of anatomy, med school specific anatomy, not just your high school anatomy where they go through every single part of your body, just like teaching you, trying to shove it in your brain without much clinical relevance. So we can definitely go through the brain today, but I do encourage you guys to, if you guys are getting ready for medical school or if you guys are getting ready for STEP, it'll be a really fun time to kind of go through all that before you start school or your test. Okay, so, wow, I see a lot of chats. Yeah, we have a couple hundred participants. So I do encourage you guys to ask questions, answer questions. I'm gonna be asking you guys a lot of questions as well. I can't dwell too long on each question just because I have a lot of material to go through. But yeah, feel free to use the chat and let's try to have as much fun as possible. So clinical neuroanatomy, the brain. So this is a brief overview. I want you guys to understand that anatomy is the basis of pretty much everything. Anatomy explains physiology, which can explain pathology, and we can get treatment from that. So our school, we actually don't call anatomy classes, we call them structure, because the way structure is, we learn structure to understand a function, which is physiology. And we can have structural abnormalities, which can directly cause pathology, but the structure can cause aberrance in the physiology, which is going to cause pathology. And as future clinicians, you guys have to think in this way to kind of come up with treatments and come up with the best plan for your patients. So this talk will be a brief and high yield, emphasis on the high yield overview of anatomy, neuroanatomy with focus on clinical and neurosurgical relevance. Radiology will be a key component of this talk, so it's okay if you guys are not too comfortable with head CTs, head MRIs. I'll try to like orient you guys, but it is a critical component to neurosurgical training or any surgical training or even medical training. So I really encourage you guys to try to read your own images, try to look at images and try to make sense of it, because that's the best way to learn. Also, another thing is there's going to be a lot of detail in this session, I'm not expecting you guys to absorb everything. The main purpose of this session is for you guys to kind of have a primer before you go to medical school, before you start practicing, to just have a good understanding of how clinicians think, how they learn, how they kind of understand anatomy. So this is going to be the biggest difference between kind of like your high school anatomy and physiology course and your medical school anatomy and physiology course is everything kind of has to have clinical relevance, well, ideally. So I'll try to hit you guys in different aspects of the same topic so that you guys can really understand and kind of, let's say 2 years later, when you guys are in medical school and learning about the brain, you guys can kind of think, oh, I remember Brendan telling me about this case, or Brendan telling me about this quick clinical pearl, so that you guys can refresh your memory really quickly. So I'm checking the chat before I move on. Yeah, so the slides you guys can see the slides right now. There's when I'm sharing, correct? So I'm gonna send this to Quinn. She can hopefully upload it somewhere so you guys can access it. Next week, I'm gonna have one of my best friends teach spine anatomy next week on Tuesday. So he's gonna go through that. So both of our slide decks are gonna be sent to Quinn. She can upload it and you guys can have access to it. And I believe this meeting is recorded. So this is also gonna be on the YouTube page. So let's dive right in. So we're gonna start with the cranial bones. I'm sure you guys saw this picture numerous times, so I'm gonna quickly go through this. The skull is made up of 22 bones, and the cranium, which is the part that actually protects the brain, is composed of 8. So there are 8 cranial bones. I'm gonna get my laser pointer out. So we have the frontal right here, makes sense, it's in the front, there's only one of them. We also have the parietal right here, right behind the frontal. We have an occipital, which is in the back of your head. We have 2 parietals, so there's going to be two temporals, so there's going to be one here and one on the other side. And there are actually 2 parietal bones as well. That's going to be closed in by sutures. So a quick question here, feel free to use a chat, is what is the significance of this circled area right here? To give you a hint, it is a type of suture. Perfect, I see Noor. It is the pterion. Do you guys know what the clinical significance of it is? I see some hemorrhagic site. Meninge media is underneath, perfect. Bleeding up the middle meningeal artery, perfect. So I see there's some medical students or some students who are familiar with neurotrauma. So yeah, this is where the middle meningeal artery runs, the MMA. So this diagram, I'm not a huge fan because it looks like it's running outside of your skull, but this is actually underneath your skull. So this artery is running between the brain and the skull. And this area right here, the pterion, it is a very weak point. It's a suture where the temporal, the sphenoid, the frontal, and the parietal bones meet. And I couldn't tell you why it's a weak point, but it is very sensitive in terms of trauma. So if you get any sort of head trauma, for example, like a ski accident or getting hit by a baseball bat, in this kind of like this temporal area, the middle meningeal artery can rupture and cause an epidural hematoma. Oh, and I see a lot of people mentioning my background. I forgot to mention this. So I'm sure you guys are aware of this background. And the reason why I put it is because I really do think the space is just like our brain. We can image it all we want, but it's gonna take a while for us to understand what it is. So I just thought it was kind of fun to put it as my background. But yeah, I do see a lot of similarity between like space and our brain. So that's why I chose this one. Okay, so moving on to sutures. This is just going to be a quick diagram explaining what the point of sutures are. So our sutures aren't really fused. So our cranial bones aren't fused when we were born. I'm sure you guys are aware of this. So a baby's head is very malleable. The brain is growing. They're absorbing a lot of information, needs time to grow. So the skull expands with the brain. And once it's kind of all ready to be fused, the sutures fuse and form, or the cranial bones fuse and form these sutures right here. So there's a sagittal suture, coronal suture. Don't worry too much about the names, but what can happen when these cranial bones fuse too early as an infant, it can cause abnormalities of how your brain is going to expand and how your skull is going to be shaped. So this is called craniosynostosis. You can see, for an example right here, if the sagittal suture is already fused, so the red line means that it's fused a little too early. It makes sense that it's not going to be able to expand laterally, and the baby's brain and skull is going to kind of elongate and get vertically longer. Does that make sense for everyone? Can you guys just give me a yes or make sense? Any questions? Perfect. Perfect. So I'm sure you guys may or may not have seen this. This is a cute picture of kind of a helmet that can help these babies reshape and reform the skull so that it kind of goes back to its normal shape. So we call that normal cephalic. So this, even during like neuro exams and physical exams, one of the things that we kind of mention would say normal cephalic atraumatic head. So that would mean that the head and the skull is just normally kind of developed. This is the skull base. It's one of the most intricate and kind of honestly very difficult to kind of absorb and understand the anatomy. So again, from this session, you can probably have a whole session just on the skull base and the cranial nerves. So I'm not going to go too crazy on it, but the general idea is, again, it's protecting the brain. It is a skull. And there are a lot of, and it's kind of a gateway between the brain, the spine, and to the spine and the rest of the body. So we have a lot of nerves, arteries, and veins. Those three will always go together. So whenever professors ask you something, just don't forget VAN. Veins, arteries, and nerves, VAN. So those three they always travel together, not necessarily all three together, but they generally travel together. So from these foramen that we call, it's a fancy word of saying holes. So these foramen from the skull down to the spine and the rest of your body, we need these foramen to kind of help protect the nerves and the arteries and the veins and have them safely travel down to our body. So a couple important features. So this slide is probably going to be the most intimidating slide. The only foramens that I really want you guys to focus now are the greater foramen right here. So this is also called the foramen magnum. Kira, yeah, there are MMAs on both sides. So yeah, I only showed you one lateral side, but there are both sides. So if you get hit on either side, same issue of epidural hematoma. And I'll be showing you some CT scans for that. So a couple foramens I want you guys to focus on are the greater foramen, so the foramen magnum. So this is generally going to house anything related to the spinal cord, including the vertebral artery, which travels with the spinal cord, the vertebral artery and the basilar artery and the anterior spinal artery. So anything color-coded in red are the arteries. Again, I'm not expecting you guys to memorize all this, but the general idea, greater foramen / foramen magnum, spinal cord, vertebral artery, and anterior spinal arteries and posterior spinal arteries. If there's an anterior for anything, there's always a posterior. That's just how nomenclature works in anatomy. The jugular foramen, this is where the jugular vein runs, not surprisingly. And a couple cranial nerves that also run along with it are 9, 10, and 11. The glossopharyngeal nerve, the vagus nerve, and the accessory nerve. The main cranial nerve I want you guys to focus here is the vagus nerve. The vagus nerve is extremely important. And I believe Dr. Rogers was talking about vagus nerve stimulation and so forth for pediatric populations. This is where the vagus nerve is running. The carotid canal, right here. It's right kind of anterior to the jugular foramen. This, not surprisingly, is where the carotid artery runs. It's probably the most important cerebrovascular structure that feeds the brain. So it is really important. So it has the internal carotid artery, carotid sympathetic plexus, which is just another plexi that kind of helps us control our autonomic system in our body. So it would increase or decrease our heart rate and so forth. So those three foramen, I really want you guys to kind of understand. We have a lot of other foramen up here that has other vascular structures and cranial nerves running, which I will be going through later in the talk. But this is kind of the quick primer for the skull base and the foramens. Okay, so our first clinical case. So we see this is the CT. This is the coronal slide. This is the axial slide. So it's color coded for you guys. So the red kind of lines here, they're the fractures. There are a lot of fractures. This patient probably fell off a ladder, like 10, 15 feet, probably doing roofing, fell first on his or her head. So my first question for you guys is, when they come into your emergency department and you're consulted by the emergency department physician being like, oh, we have a patient, 30-year-old man, fell 20 feet from his roof. Can you come down and please evaluate this patient? What would you expect from physical exam just by looking at this patient? I'll give you guys a couple seconds. DCL, okay. Raccoon eyes, I like it. GC scale, CSF out of the nose, CSF out of the ears, battle sign. You guys are already experts. I don't know why I'm giving this talk. Yeah, so this is a quick example. If you have a skull base fracture, the reason why you have CSF leak is, I mean, there's a lot of CSF. In the skull, as I said before, it protects the brain, and the CSF is kind of like a cushion for your brain. Your brain is constantly moving around inside the skull, and it kind of acts as a cushion. So when there is a leak, or in this case, it's kind of like a huge full-on fracture, so it's constantly leaking, you would see autourea, rhinorrhea, or CSF autourea. So there are ways to check, oh, it may look just like blood. And when you do a test on it, you can actually see this halo sign where the blood and the CSF kind of separates from each other. This is all chemistry. So you guys might know more about this than me. But so this is a quick way to check, oh, there is CSF in the blood. You should never have CSF and blood kind of mixed in when you're doing a test. This is the battle sign. I think a couple of you guys mentioned. So you would see in the mastoid process, you would see a lot of bruising. This is just blood pooling in there since the skull can't contain the blood that's surrounding the brain. Hemotympanum. So this is, if you do a fun otoscopic exam, you would see kind of your tympanic membrane bulging out. This is also due to just blood accumulation. Raccoon eyes. So this is just, you can see right here in the CT scan, if this superior orbital floor is broken, you would obviously have blood and CSF kind of pool there as well. So that's another sign you can also see. I see a lot of good other anxious concussions, of course, deformity of the face and so forth. So yeah, this is kind of the general idea of what you would expect in a skull-based trauma. The first thing you should be looking at, you see raccoon eyes, do otoscopic exam, battler sign, and autourea, rhinorrhea, and have CSF. The patient would have to go into the OR and get it fixed. There are minute CSF leaks, not these huge fractures, but we call it CSF leaks. So if there's like a hairline fracture and your CSF is slowly leaking, do you maybe know what the patient might be concerned about, or what they would come to your clinic and tell you? There's a yeah, a lot of these would have to be evacuated. Erosion of CSF, so it would kind of leak from your tympanic membrane. So can anybody tell me what you would expect from a hairline CSF leak? Dizziness, perfect. So a lot of postural hypotension, like postural headaches. So, I mean, that's pretty much it. It's kind of like a buzzword. So when a patient comes into your clinic and says, oh, doc, like, I don't have this headache all the time, but whenever I kind of lay down, or like whenever I kind of lay up or stand up, I'm having this like kind of diffuse headache, then you would want to check for a CSF leak. And a way to do this is a CT scan, and the radiologist will be able to find those small hairline fractures. Yeah, vertigo, a lot of patients say dizziness, disorientation. Running, you wouldn't really see runny nose because that's only for huge fractures when you have constant CSF leaking. But these are more for like hairline fractures where you can't grossly see any CSF leaking, but yeah, you would suspect that there's like a hairline fracture. So moving on. This is the meninges and the meningeal spaces. So from now, I'm kind of going to go from outside to in. So we started with the skull. I'm going to be going through the meninges. We'll be going through the cortex and then so forth. So I'm sure you guys are aware of what the meninges are. We have the dura mater, the arachnoid matter, and the pia mater. So the dura mater is probably the thickest. If you have been to any neurosurgical cases, the first thing you see, it's very when you do a craniotomy, is the dura. It's very shiny. It's a thick, kind of like a saran wrap sort of texture. Right under that, you would have the arachnoid, which is a thinner inner layer. A lot of like blood vessels live here, so you can see right here. And one thing I want you guys to note are these arachnoid granulations. It's going to come up later when I talk about kind of CSF drainage and more of the cerebral venous drainage. I'm not going to be talking about like the venous drainage too much right now. I'm going to be talking about it later. But I want you guys to know that these arachnoid granulations help CSF drain into the sinuses, the cerebral sinuses. And under the subarachnoid space, we have the pia mater. So that's going to be kind of surrounding the brain, like right out of the brain. It's really hard to grossly see because it's so thin. But you do have to understand that we do have this very thin layer surrounding the brain. This is very similar to like visceral and parietal sort of layers of like your organs. It's very similar. It's the same idea. So it's like the visceral layer of the brain. That's the pia mater. And the dura mater is kind of like the parietal layer of the brain. So the only real kind of space where you can see, like grossly see the space, is the subarachnoid space between the pia mater and the subarachnoid, the arachnoid area. So do you know why that space is, like the subarachnoid space, may be important? Yep, that's where the CSF is positive. That's where we have a lot of the CSF is, yep. It's not produced there. The CSF is produced in the ventricles. Yep, perfect. Yeah, so it's gonna, the subarachnoid space is gonna have CSF. And again, when CSF and blood mixes, it's not fun. It's never good. So one way to check, I'm sure you guys have heard of subarachnoid hemorrhages. So we're gonna jump right into this clinical case. 53-year-old man presents to the ED with quote unquote worst headache of her life. I actually should have wrote his, I apologize. That started suddenly in the afternoon. He's expecting photophobia, experiencing photophobia, has nuchal rigidity, which means kind of your neck area is very stiff. So what would you expect in his CT scan? A, B, C, or D? I'm not going to give you too many hints. Okay, some people are saying C, some people are saying D. Some people are saying A, that's good. I see a lot of different answers. Yeah, this one's a little tricky. I did this on purpose because for people who have a little bit of a medical experience, your typical subarachnoid hemorrhage would look like, you would expect like a star sign filling up the different areas. So the answer is C. You do see this space outside of the cortex. So a lot of these squiggly lines, it's the sulci and the gyri, which I'm going to go over in a little bit. And outside of the space is pretty much, you can expect it to be the subarachnoid space. And in C, you see the subarachnoid space being filled up with blood. And how do I know this is blood? Is because it's bright. It contains a lot, blood contains a lot of iron. So acute bleeding on a CT scan is going to appear bright. That's a very, very important concept that you guys have to know. Acute blood, active bleeding in the brain for a CT scan is going to appear bright. And I really want you guys to understand that. So can anybody tell me what A is? Right, this is an epidural hematoma. And how do I know that? It's because it's confined by the sutures. So I mentioned sutures earlier, and the reason why I talked about it was not because of cranial synostosis, but because of its importance in the different types of hematoma and hemorrhages. An epidural hematoma, just because the dura mater is anchored in the different sutures, if there's bleeding in the epidural space, it will never cross those suture lines. It's really, really important. Yeah, so I see a lot of participants writing MMA. This is when your MMA should be popping up in your head. When I mentioned epidural hematoma, the 3 letters MMA should pop up in your head. And the other concept is crescent-shaped. Some people say it's like a lens shape, but you want to see a clear demarcation of the hematoma because the dura is anchored in the different sutures of the brain. So that's really, really important. So this is where the whole structure, function, and pathology comes in. It all kind of ties in together. So the treatment for this, you would have to make a small craniotomy here and remove the blood. And why is that? Because you don't want increased pressure in your brain. If there's increased pressure in your brain, also called ICP, so if there's increased intracranial pressure, that's a no-no. That's a big neurosurgical emergency. You would have to take the patient down to the OR, do a hemicraniectomy, so pretty much taking out this entire skull, or half of the skull, and relieving pressure of the brain, and allow the swelling to go down. And the neuro ICU, they do magic to kind of stabilize the patient, and then they can come back to their normal function. Yeah, increased ICP can lead to herniation. I'm going to be talking about herniation as well, so just hang in there. So what is B? So I told you acute blood is bright on CT. And you do see this acute brightness. Intraparenchymal hemorrhage, perfect. So this is when the blood vessels actually just rupture. I'm going to be talking about this later as well, but it's hemorrhaging into the brain tissue. Excuse me, it's going to be hemorrhaging into the brain tissue. This can also lead to increased ICP as well. So it is a neurosurgical, I wouldn't say it's an emergency, but you do have to monitor a patient, do neuro exams every hour and so forth, and really monitor a patient. This would be a neuro ICU patient as well. And last but not least, D. Can you guys tell me what that is? Perfect. Subdural hematoma due to rupture of the bridging veins. Wow, it's like somebody just copied and pasted from the textbook. It was perfectly said. Can be seen in shaken baby syndrome. Perfect. And it's more of, I said crescent earlier here. I guess a better way is like a lens, and the crescent would be here. It's like a more elongated, and it crosses the suture lines. So you see here in the epidural, the suture lines are approximately over here, which I would, let's say these 2 dots are sutures. These are not sutures, but let's say these are, and it's definitely crossing the suture line. And this is because the subdural space it's not anchored. Like the dura is anchored into the skull, but the space underneath that, there's nothing anchoring to any area. So it's just kind of a diffuse, blood is just pooling into that area as well. So you see a lot of these in elderly patients, like patients who potentially fall, who have a higher fall risk and hit their head. And even if it's not a huge trauma and the patient doesn't go to the ER right away that day, this can present in, let's say, months. So a patient will come into your clinic being like, hey, doc, I've been having a lot of a headache, some visual changes, and I haven't had really huge trauma recently, but I guess like 3 months ago, I fell once. Then that's like a huge kind of like a bing, bing, bing of, oh, this might be a subdural hematoma. You would want to do a CT scan and confirm your diagnosis. C is the subarachnoid hemorrhage. So that was, C was the answer for this case. So just checking the chat. Yeah, it seems like a lot of the questions were answered. Okay, so let's move on. I hope this is clear. This is really, really important. These 4, if you know how to kind of differentiate these 4 images and the pathology, you are already leaps and bounds beyond like the average pre-medical student, because this is very, very high yield and it will come up. I can guarantee it will come up in any medical school test. So I'm going to be flying through this because I talked about it a lot. The epidural hematoma, again, you see, so the previous one, the sutures were up here. This is another suture in the back and in the temporal region. So you see the epidural hematoma here. This is an axial slide. This is the coronal slide. So you can see that it's perfectly inbound of those suture areas. So epidural hematoma bound by the sutures because the dura is anchored in the sutures. I'm not repeating what I'm saying because I forgot I said it. I'm saying it because it's important. And I really want you guys to hammer this like topic and concept home. Dura, anchored in the sutures, epidural hematoma, confined by the sutures. And yeah, this is the middle meningeal artery that I was talking about. So this, I really, really do like this diagram. Does it look different depending on the blood supply? Not really, because since MMA is the most common, there are obviously other branches, other arteries that run through, and any sort of blood vessel rupture is gonna, if it's within those space, like the two sutures, it's gonna present pretty much the same. Subdural hematoma, again, this is the biggest space, or not the biggest space, under the dura, where we have some space. A lot of the bridging veins, as you guys mentioned, it's going to be pooling. So it's more of like I saw one of the chat, you guys mentioned a banana. Yeah, it's like a banana forming all around your brain, pretty much. I've never really seen it cross the hemisphere, like a left subdural hematoma crossing to the right. But yeah, you definitely see this crossing the suture lines. So a quick question here. What is the difference between the left and right CT subdural hematomas? This is actually this is kind of a higher level question, but it is really important. Yeah, it's acute and chronic. Perfect. Yeah, really, really happy some of you guys know this. So I said this before, acute bleeding, acute blood on CT is very, very bright. I know the calibration is a little different, but you can tell that this blood right here is active bleeding. So this is an acute subdural hematoma. So this is someone who probably fell a couple of days ago, like an elderly patient coming in with a lot of headache. This is what you would expect. This one, you see it's a lot darker. So this means it's chronic blood that's been pooling and pooling. And one thing I really, really want you guys to understand, this is a pretty new concept so chronic subdural hematomas, it's a pretty new kind of concept because there's been a lot of treatment like MMA embolizations. But it's a very different pathological process between acute and chronic. Acute is what I've been talking about. It's when your bridging veins kind of rupture and you have active pooling in that blood. Subdural or chronic subdural hematoma is more of a chronic process, and it's not really the bridging veins causing the bleeding. Because if the bridging veins are leaking, it's active bleeding. You're going to have bright blood in the CT scan. But the reason why this is kind of darker and more chronic is because this is actually very, very small amounts of blood leaking from the MMA artery, which is kind of mind-blowing because I've been kind of hammering MMA and epidural hematoma. But I also want you guys to keep in the back of your head, MMA is also responsible for chronic subdural hematomas. Do you guys understand that? If you drop this knowledge in your neurology rotation or neurosurgical rotation, people will be impressed. I can promise you that. And that's why new treatments such as MMA embolization, which is endovascularly coiling off the MMA can treat chronic subdural hematomas. And Dr. Link at Northwell is one of the pioneers. He's done a lot of research on this. He's published a lot of clinical papers. And it's like a new hot topic in neurosurgery. Like this is actually, they talk about this in conferences nowadays as a new emerging technique for treating chronic subdural hematomas. So yeah, that's like the main difference between the left and right. Subarachnoid hemorrhage, I talked about this earlier as well, so I'm going to briefly talk about this again. This is the SAR sign that I mentioned before. This is not something, so the one before, it was filling up the space outside of the cortices. This is kind of filling up the inside parts of the cortices. The most common cause is a berry aneurysm. So any sort of aneurysms, but berry aneurysms rupturing is a huge cause. So I told you a lot of these big blood vessels live under the subarachnoids, or live in the subarachnoid space under the arachnoid matter. So when these blood vessels ruptured, especially the arteries, blood's going to pull really, really fast in these spaces. So can anybody tell me a genetic disorder that berry aneurysms are very, very common? This is a very high yield step question, actually. Perfect, Marfan's. Yeah, it is Marfan's disease. For people who don't know Marfan's disease, it's a connective tissue disorder. So connective tissue, it's pretty much composed everywhere in your body, but blood vessels have a lot of connective tissue. It's when kind of your connective tissues aren't perfectly forming. So your blood vessels, even when it's supposed to be straight, kind of gets elastic. It becomes more elastic and forms these aneurysms, because aneurysms are pretty much the walls of your vessels not being strong enough to contain kind of like its structure, so it balloons out. Does that make sense? So if you have a long balloon, for example, if one side of it becomes thin, that side is going to balloon up, right? So it's the same idea. Aneurysms, it's not rocket science. It's just pretty much that area of the blood vessel is kind of ballooning out because the walls became weaker. And in Marfan's, the walls are generally weaker because it's a connective tissue disorder. So you would expect a lot of berry aneurysms and subarachnoid hemorrhages from these patients. And you don't necessarily need aneurysms to have a subarachnoid hemorrhage. So I don't want you guys to think there's a must. And a general guide for medicine, they're never say always, because there are always exceptions and it's just general guidelines. Okay, so just checking the chat. Oh, polycystic kidney disease. Yeah, this is another great example of aneurysm formations. I'm really happy you brought that up, Nadia. Perfect. So the external anatomy, I'm sure you guys heard me say gyri and sulci, or sulci, whatever it is. Gyri means the folds, so the part that's actually folding and folded up. Sulci are the small grooves, so the fissures in between. So, and the fissures are, I guess, the larger grooves. And the significance of fissures, so a really important fissure right here, lateral fissure. Does anybody know what else this is called? It's someone's name. Yep, sylvian fissure. So this kind of separates the temporal lobe to the frontal and the parietal lobe. And it's really important because one thing you have to understand is not everything's, the cortex isn't just the most outer part of your brain. If I'm going to show you other diagrams, but the cortex kind of folds in, like I said, and then comes back out. So the temporal lobe folds in and comes back out to become the frontal and the parietal lobe. So there are cortices kind of folded in. So if this is the frontal lobe and this is the temporal lobe, my fingers are also the cortex. And this part is the fissure. So if I open up the fissure, you should be able to access the deeper parts of the cortices. So I want you guys to understand that. If you open up the fissures, you still see cortex. And they all have functions. So when you're doing cortical mapping, let's say you have a big brain tumor kind of deep in the cortex, one way to approach that, neurosurgery is all about approach. Like, how am I going to approach this area, this tumor, this aneurysm that's deep in the brain, whatever it is. It's all about approach. And using this fissure and being able to retract and access those deep structures, very, very important. And this can also go for the longitudinal fissure, which is pretty much right above the corpus callosum. So when you separate the two hemispheres, you can access the deep structures. So that's kind of like the clinical significance of these fissures. And another thing I quickly want to go through is the embryological kind of derivatives of your brain. There's a telencephalon, which is the cortices, diencephalon, which is the deeper parts like the basal ganglia, thalamus, and so forth. The mesencephalon, which is the midbrain, pons and the cerebellum, which is the metencephalon, and myencephalon, which is the medulla. One way to memorize, this is annoyingly kind of important. One way I memorize this is, it's kind of a mnemonic. Tell Diane, mes met my. So you're telling Diana, so tell Diane, whoever is mes met my. So tell Diane, mes met my, from outside to in. Telencephalon, diencephalon, mesencephalon, metencephalon, and myencephalon. So tell Diane, mes met my. And if you just think from cortex to thalamus to midbrain, pons, and medulla, you should be able to kind of line those up pretty well. So the cortex, I'm sure you guys have seen this picture a ton of times as well. We have the frontal lobe covered by the frontal part of your cranial bone, the parietal lobe, which is covered by the parietal cranial bones, temporal lobe covered by the temporal cranial bones. So you guys kind of get where I'm getting at, right? It's all kind of the same name and the same nomenclature as your cranial bones. So if you have that in mind, it's going to be a lot easier to figure out where each lobe are. And this occipital lobe I told you about. The frontal lobe and the parietal lobe, the main landmark that separates it is the central sulcus. So this is really, really important as a neurosurgeon. You identify the central sulcus, especially if you're trying to do cortical mapping. So like if you're doing like a meningeal resection, and if the meningeal is like really into the cortex, you want to make sure you're not kind of taking out cortical areas that are really important. So they work with the neurophysiologists, and I'm sure you guys have heard of like awake craniotomies, so they can check for language. They're also just, even if the patient is asleep, there are ways to use electrodes to check for signals. So yeah, cortical mapping, really, really important. So the frontal lobe, it's a lot of, so this kind of like, it's motor and executive function. So the orbital frontal cortex right here is more of like higher order, complex, just like executive functioning. And the motor cortex here, shown by the homunculus, is kind of like the motor function of the frontal cortex. The parietal cortex is a lot of sensory. So this is another homunculus showing your sensory distribution. So this is the medial part of your brain. So this is where to orient you guys, this is where the corpus callosum would be. This is where the other side of the brain would be. So this is kind of the part of the brain you would see outside, and this is the part you won't see unless you kind of retract the fissure. And this is going down into the temporal lobe. So this is the temporal lobe. And you can see here, this is the sylvian fissure I was telling you about, which is really important. It folds in to complete the primary motor cortex and the primary sensory cortex. And one way to memorize the homunculus, this is actually really important that you understand this. The medial part, which is towards the median part of your brain, it's more of your foot to your leg. And then I kind of envision someone laying down. I kind of envision more of this picture, someone kind of laying down in the beach with their legs hanging off, kind of like a cliff or whatever. The beach is right here, and you're just getting a nice suntan with your arms up. And then it's your face. So I kind of envision starting from medial to lateral, your feet hanging to your body, to your arms, and then just your face kind of hanging down to the rest of your cortex. So the deep inside your legs, body, face is probably around right here. So you guys see my laser? And then your tongue and other areas would be right here. And this is important because when patients get strokes, it's really hard to get a stroke that only affects, for example, this motor cortex, because that's just not how clots work. When a clot dislodges and blocks off blood supply, which is one way of getting a stroke, ischemic stroke, it's going to affect a territory. So I'm going to show you more diagrams about this. But if it affects one territory, it's probably going to affect this whole area. So for an example, if it affects the MCA, the biggest part of the MCA, it's probably going to affect all of this. So you're going to expect not just facial paralysis, but also arm paralysis. And you would expect less of leg weakness. Does that make sense? So if you see someone with facial paralysis and leg paralysis, that means this patient either had a hemorrhagic stroke, which is a much bigger stroke, or a tandem occlusion, which means this patient just had a massive, massive ischemic stroke, like a huge clot. I'll be showing you guys the circle of Willis, like a massive, massive stroke affecting this entire motor cortex. So that's one way of figuring out where the clot dislodged and is causing an ischemic stroke is just by doing a neuro exam. By seeing where the deficits are, you can kind of exactly pinpoint which part of the artery is affected, causing this clinical presentation. Does that make sense? I feel like I just talked a lot. Can you guys just give me a thumbs up if you guys are good? All right, awesome, cool. Actually, we're kind of running low on time, so I'm gonna try to run through these. So these two are strokes. You can tell the dark area means that cells are dying. And you can already tell this isn't a hemorrhagic stroke, because if it's a hemorrhagic stroke, you would expect bright blood in here. So this dark area means it's dead brain tissue. And neuroradiology 101, always your best bet is to compare it to the other contralateral side. So yeah, if you compare it with here, you see it as darker area here as well. So this phenomenon, I see some people writing it on the track, and it's hemi-neglect. So this patient is neglecting the entirety of, well, not entirely, but a lot of her left side. So which area of the brain is affected to cause this sort of phenomenon? I mean, you guys can kind of figure it out by just a location, but it is a little tricky. Right side, yeah, it's the right side, but what lobe? Right parietal lobe, perfect. Yeah, so this is a parietal lesion causing hemi-neglect in a patient. So you would also expect some sensory deficits as well in this patient, since it is in the parietal lobe. If I go back here, the parietal lobe is here. So you would, whatever sensory deficit, according to this funcalist, you would have, but you would also have hemi-neglect. This means that it's a phenomenon where the patient kind of neglects the entirety of their left side. So if I tell them, if somebody brings up their left hand to their eyes, I've seen this in the wards, it's actually unbelievable. If the stroke neurologist brings up the patient's hand up to their eyes, they're gonna be like, wait, this is your hand, this is not my hand, because they're just entirely neglecting the left side of their brain. It's crazy. This is an occipital lobe infarct, obviously causing visual changes. I try to line this up with the visual deficit. So you see right-sided deficit. So this patient is having right-sided visual loss. And I'm sure you guys learned this a bunch during your AP biology or college biology courses. Your visual system crosses in the optic chiasm. So you would expect left occipital deficit. Yeah, so you do see macular sparing as well, which is right here as well. So moving on, these two, I'm gonna just quickly ask this. Do you guys happen to know what, so this is CT and MRI, what these are scans, what kind of patients these are scans of? And to give you a hint, this is not a neurosurgical patient. Dementia, perfect. Yeah, I'm really happy you guys knew this. So this is the temporal lobe, as I told you about. It folds in, so it looks a little weird. But you see the space being a lot robust than a normal healthy brain. You can't compare this to the other side because this is kind of a systemic atrophy of the cerebral cortex. But the top one is a Alzheimer's patient. So you see a lot more space in the cortex. It's subtle, but you definitely see it. And the bottom one is actually a chronic schizophrenic patient. So it's amazing how you actually do see cortical changes in psychiatric disorders. It's very, very real. So yeah, you see kind of similar cortical atrophy as well in schizophrenic patients. So this is a pretty easy question. What connects the two cerebral hemispheres? Just like pop it in the chat. Perfect. It's the corpus callosum. It's kind of like the bridge between the left and right brain. I'm sure you guys heard this so many times. They have different functions. There's a dominant brain. It's not just because you're right-handed doesn't mean your left hand is, or your left hemisphere is always dominant. I believe 10-ish% have the other side dominant. So just always keep that in the back of your mind. And yeah, the left side, it's more for language, creating sentences, kind of understanding languages. And the right side is more of like spatial localization, kind of like imagining objects. And there's like a decent amount of language function as well, but it's more of like the emotional aspect of languages. But the left side is the most dominant language cortical area. But I have seen in the hospital where the right hemisphere was the dominant cortex for language for a couple patients. So aphasia, Broca's aphasia, and Wernicke's aphasia. Broca's aphasia, it's in the motor cortex. So you would expect patients to not be able to produce. So these patients can have perfectly formed sentences in their head, but when they try to produce, it's gonna sound very, very broken. Wernicke's area, so this is actually the temporal lobe, not the parietal lobe. I actually got this question wrong in one of the shelf exams because I always envisioned this, but this is in the border of the temporal lobe and the parietal lobe, but Wernicke's area is technically in the temporal lobe. And this is where a lot of language thinking occurs. So when you have Wernicke's aphasia, these patients would be able to, for a non-English speaker, they would sound fluent. They're speaking, all the words are kind of like fluent, but when you try to understand what they're saying, it makes absolutely no sense. So it's more of a word salad. And there's an arcuate fasciculus that connects the Wernicke's aphasia to Broca's aphasia. So one way I kind of memorize this is you always want to think before you speak. So you want to think Wernicke's area goes to the Broca's area to speak, right? So you want to think before you speak. So if you want to think of the deficits, that's how I always think of it. Wernicke's area is damaged. Oh, so your thinking is damaged. So that means you can produce and you can speak well, but you're not going to make any sense. Broca's aphasia, your speaking is messed up. So you can think, but your production of words is messed up. And that also makes sense because it is in the frontal lobe. Again, this is why understanding anatomy matters a lot for physiology and pathology. Since it is in the frontal lobe, it's more of a motor function, and that's why these patients can think, but not speak well. I see a lot of questions. I'll try to address these like towards the end, just because I have a lot of material to go through, but I hope you guys really understand it. There's a lot more aphasias like transcortical aphasias, receptive aphasia and all that. But for now, just understand Wernicke's aphasia, Broca's aphasia. And yeah, think before you speak. Wernicke's to Broca's. So another clinical case, 70-year-old man with history of hypertension and atrial fibrillation is brought to the ED by EMS 1 hour after experiencing right-sided weakness and difficulty speaking. ED is concerned that he might be having a stroke. What's the next step? I'll give you guys a couple seconds. Good, I see a lot of different answers, which is what I like. So I see a lot of E, some C. Okay, so the answer is actually B. And the reason why, I mean, so this question, it's really important. What's the next step? I'm not saying you're not going to do a cerebral angiography and thrombectomy, but the first thing you want to do in a stroke code, and this is when the hospital announced stroke code, please come down, whoever is on call for stroke neurology. The first thing they do, neuro exam, and then straight to CT. And the reason why is because I kind of mentioned this before, the patient may have an ischemic or hemorrhagic stroke. Oh, sorry. I meant CT head without contrast. So C is the answer, not B. If I said B, I totally apologize. The answer is C, CT head without contrast. Because you might have ischemic contrast or ischemic infarct or hemorrhagic infarct. These are two different pathologies. They're strokes, but they're two different pathologies. One is due to lack of blood flow. So this is ischemic stroke. One is due to hemorrhagic stroke. So this is when the blood vessels rupture and cause an hemorrhage. And the reason why you want to differentiate these two is because of TPA. If the patient came in within 6 hours of symptom onset, you want to give the patient TPA. TPA is a clot dissolver. So if there is a clot blocking the MCA, You want to dissolve that clot and eventually do a thrombectomy. But you never want to give TPA to a hemorrhagic stroke patient. And that probably should be intuitive. If you're hemorrhaging out of your brain, you don't want to give a medication that's going to help the brain kind of break clots and keep on bleeding when the brain is actively trying to stop that bleeding. Does that make sense? Really, really important point. Okay, so yeah, after you identify, let's say the patient did have an infarct, they find that you can also do a CT angiography. So this is different from CT contrast. CT angiography, you can directly visualize the blood vessels, and you can potentially see a clot, let's say in the MCA region, causing that infarct. And you can do endovascularly, go up with a catheter, take out the clot. The patient will sometimes be completely back to normal as long as they come in at the right time. So in terms of times, this is something that's been a pretty recent, not recent, but like 2016, they stretched the thrombectomy with timeline window to 24 hours. So if the patient comes in within 24 hours of symptom onset, they can always benefit from a thrombectomy. So this is the cerebrovascular anatomy. I'm sure you guys have heard of circle of Willis. It's not really a circle. And it's another thing I really want you guys to understand is it's not always complete. It's actually only, I think it's like less than 10% of the population has a complete circle of Willis, meaning there's a anterior cerebral artery connecting this area, posterior communicating artery, you don't really see all 4 of these communicating arteries in all these patients. So the general flow, you have the ICA coming up. This is the biggest, this is through the carotid canal. I'm sure you guys remember from a little earlier. And it feeds generally the MCA and the ACA. This is A1, A2, anterior communicating artery. There's only one anterior communicating artery. However, there are 2 posterior communicating artery in the posterior circulation. This is also really important for you to understand the anterior circulation and posterior circulation. Anterior circulation mostly comes from the carotid arteries. Posterior circulation mostly comes from the vertebral arteries and the basilar arteries. So the vertebral arteries coming off from the subclavian artery forms the basilar artery, which is just one. This feeds generally the pons of your brainstem and a lot of your brainstem. So you see a lot of these branches and the cerebellum. So you don't have to understand all this now, but you have something called pica, posterior inferior cerebellar artery coming out from the vertebral artery. You have ICA, you have SCA, superior cerebellar artery. So a lot of the posterior circulation, including the cerebellum, comes off the basilar artery. So this is the high yield point. Anterior circulation, carotid, posterior circulation, vertebral, and basilar. So this is a distribution. I really wanted you guys to understand. ACA is going to be the medial aspect of the cortices. So if you have an ACA stroke, which limb would you expect to be a deficit? Your upper extremities or your lower extremities? Really, really important. Exactly, lower. So this is one way to understand, oh, there's a clot blocking up right here in A2 versus like the MCA is just by looking at their neurological deficits. So I really want you guys to understand that. So a lot of the medial parts of the motor cortex and the sensory cortex, ACA, a lot of the lateral chunks are the MCA, posterior circulation, including the deeper surfaces. It's going to be PCA in the posterior circulation. So if you have both upper and lower extremity deficits, you can expect a clot like here. This is called a tandem occlusion, which is kind of at the verge of the ICA and the MCA and the ACA so that it blocks off ACA and MCA occlusion. So why doesn't everyone have a complete circle of Willis? This is, you can ask the man upstairs, just embryology. So again, this is quickly the cerebrovascular anatomy, basilar artery feeding the pons, and then ACA, and then MCA, and a lot of the branches. The name of the occlusion, tandem occlusion. Tandem, T-A-N-D-E-M. So I'm going to rush through these since I have only 2 minutes. Basal ganglia, it's a lot of fine motor control. You really don't have to learn the specific anatomies now, but I want you guys to know it's surrounding the ventricles pretty much. And it's kind of in this meaty area. And directly surrounding the ventricles, you have the caudate, which is part of the basal ganglia, and you have the putamen and the globus pallidus and so forth. This is all for fine motor control. So this is the blood supply. You can see the MCA. This is the middle cerebral artery. And the branches of the middle cerebral artery called the lenticular striate arteries feed the basal ganglia. So you can have, this is not mostly due to, what's it called? Embolic strokes, but this is more due to lipohyaluronidinosis, which is due to hypertension. So if you have a lot of hypertensive smoking patients, this areas get very thick and cause ischemic strokes. Again, basal ganglia, kind of the clinical significance, you have Huntington's disease, Parkinson's disease. Again, I don't want you guys to understand all the pathways now. You do have to understand the pathways eventually. There's a direct and indirect pathway for fine motor control, and they go aberrant, causing these sort of motor deficits. And what neurosurgeons can do now is DBS. So I think Dr. Rogers mentioned it is DBS. You can target the subthalamic nucleus, or kind of like the other globus pallidus interna, and implant an electrode and have certain frequencies to lower these sort of chorea or tremors. So chorea is more of like bigger involuntary movements seen in Huntington's disease, and pill rolling tremors or more Parkinson's disease patients. Thalamus, hypothalamus, and pituitary, they are kind of like the sensory relay areas. The hypothalamus is really important for homeostatic functions like eating, sleeping, body temperature, and so forth. This diagram, it's just really for you to understand. This is the hypothalamus. There's so many different functions of the hypothalamus and different regions. So this, I don't want you guys to understand all of it and memorize all of it yet, but I just want to get the point across that there are a lot of different functions of the hypothalamus. And the thalamus is kind of like a sensory relay. You can have thalamic strokes, and these are branches from the PCA, the posterior circulation. I told you, deeper brains, posterior circulation. So you can see the infarct right here. This is the MRI, which is why it's bright. So don't get this mixed up with CT scans. This is the MRI, which is why the infarct area is bright. This is not blood. This is infarcted tissue. And these patients will have pure sensory deficits. So another quick clinical case, Quinn, is it okay if I have like 2 more minutes? Or should I kind of like wrap up?
Yeah, sorry. Is there a way to wrap up? I think our next.
Yeah. So another quick thing about neurosurgeon. So this is going to be a pituitary adenoma. So the answer for this would have been an MRI head. This is actually a part of MEN syndrome, MEN1 syndrome. It's a lot of tumors in the pancreas, parathyroid, and pituitary. The triple P, PPP, MEN1 syndrome. So you see here, there's a huge pituitary adenoma here. This is a normal pituitary gland, optic chiasm, pituitary stalk, and the pituitary gland right here. There's a left and right lobe, and this whole thing is the pituitary adenoma. So what you can do is a transcranial surgery, since it's really hard to open up the brain and access it. So future brain turns are going to be able to do transcranial surgery, have this long apparatus to just pretty much evacuate the pituitary adenoma, and the patient will be back to normal. We unfortunately won't be able to have too much talk about the ventricles, but it drains out, it creates CSF, and you can have hydrocephalus. I think Dr. Rogers was talking about this. You can have obstructive, non-obstructive, and even normal pressure hydrocephalus. You can put in EVDs and kind of normalize the pressure, because again, expanding brain, no good because of increased ICP. Venous sinus system, I really wanted to go through this, but again, this helps you drain the CSF and kind of drain everything back to your heart. Very, very intricate structure, as it doesn't get as much attention as the arterial system, but it really is important because you can also get like intracranial hypertension, you can have venous anomalies and so forth. Cerebellum, it's a lot of balance. So that's kind of like the general idea for that. This is Chiari malformation. This is when the brainstem kind of gets compressed. And neurosurgeons can decompress this by literally shaving off the bottom part of your occipital skull. So you can, this is a Chiari malformation, and this is the pressure relieved. And a lot of patients, they get a lot of cerebellar symptoms, and a lot of them get relieved after the pressure is relieved. Brainstem and cranial nerves, I'm gonna have to just run through these, but this is just a lot of pathways, motor sensory pathways run through the brainstem up to your brain. And these are brain herniations. Again, this when you have epidural hematomas, you can cause herniations. And the main high yield point for this is if you get a brain stem herniating throughout, a lot of your breathing and central respiratory drive is in your brain stem. So if that part gets affected by this, it's another neurosurgical emergency. So you're going to have to do a craniotomy, evacuate the hematoma, and kind of relieve the pressure. So that's where I'm going to stop. Sorry for going over and having to rush through the end, but I really hope you guys got a lot out of this. I do have a Twitter. If you guys have any question, this is my email right here. I'll be happy to talk about neurosurgery. I'm actually interested in neuro IR, so anything talk about that, I'll be more than happy to talk about. Any high schoolers or college students applying to medical school, I'll be more than happy to talk about that. So honestly, I'm most active on Twitter, so give me a follow, just send me a DM there. And I really hope you guys had fun, a good primer before you guys learn about more brain anatomy. Thank you so much. And next week,
Thank
Tuesday,
you
is going to
so
be
much.
all about spine. So I hope you guys all tune in.
Thank you for your time, Brendan.